bodge job in the middle of the mountains or the jungle could lead on to more problems with infection because you haven't spent enough time cleaning and dressing it. So yeah, treat the environment, bothies before bandages. A quick fix, will that work?
Welcome back to the World Extreme Medicine podcast with myself, Owen Walker. In this episode, we're going to look at the principles of minor wound care with Ben Cooper. So what I want to do in the conversation is look at some of the principles of minor wound care that are universally important, regardless of location or environment. We'll look at the aspects of wound care when managing cold injuries, minor burns, minor incised wounds, fungal infections, minor cellulitic infections, abrasions, and much more. So joining me is Ben Cooper. Ben is a senior charge nurse based in Sheffield, and he's also an expedition medic and World Extreme Medicine faculty member. He's also a long-standing search and rescue instructor and member as well. Ben, welcome to the podcast.
Good evening. How are you?
I'm good, thanks. Good to catch up with you again. I wonder if we could just kick off, Ben, with just firstly getting you to speak to some general principles of good minor wound care.
Good. So it's basically stop the bleed. Wound assessment. Where is the wound? What caused it? I sort of go down a sort of approach of a look, feel, move. There's any swelling, any bruising, any deformity, any heat, size, wound, and depth of wound. And then on to wound cleaning. And then obviously solution to pollution is dilution. Ideally a bit of pressure behind that wound cleaning. And appropriate dressing, which again depends on where we are in the world, what we've got with us, antibiotic use, Rivaxis or tetanus, and a timely dressing change. With having the expedition head on a lot of the time, and from the expedition world, all these principles are very good, however, but in the expedition world, it's like, where are you? We're talking minor injuries. So do we need to do something there and then? Can we just apply a dressing and move on to a more appropriate place, a base camp, a hotel, somewhere in the middle of the jungle? Where's the next camp? If we're on a base camp trek, where's the next tea house? Do we have to do something about it there and then? Can we just put a bandage on it and basically move on to somewhere where we've got more appropriate lighting, more potentially running water, and just a bit more time that we're not rushing around and potentially slowing the group down when it sort of involves potential of group dynamics, human factors, and things like that, where are we in somewhere dangerous? How long is it going to take to actually, you've got a large wound, to clean it and close it properly, rather than let's put a bandage on it, move on. And again, if from an expedition point of view, preparing an environment, we need to, it's going to be potentially clean a surface, clean the back of a Land Rover, but preparing a sterile field around us to do an appropriate dressing, rather than getting on with it and rushing the job. And when we rush the job, we tend to potentially make the job worse. So things like good lighting, good head torch, clean environment, preparing your medical kit for the procedure that we're about to undertake. Jamie Patterson and I talk about bothies before bandages. So if my background is a lot of it's cold and polar and mountainous. So putting a group shelter up, preparing it so the casualty has, or your patient has, a warmer environment. Your kit's not, you open your med kit and on the in Scotland in the middle of winter, it's just going to get blown everywhere, covered in snow. So control the environment, win the environment, and you potentially bought yourself a more comfortable place to actually do a correct wound assessment and a better closure, rather than sort of bodging the job that potentially could, a bodge job in the middle of the mountains or the jungle could lead on to more problems with infection because you haven't spent enough time cleaning and dressing it. So yeah, treat the environment, bothies before bandages. A quick fix, will that work? I say pain relief, yes or no? And let's say documentation, size, appearance, mechanism of injury, things that you're doing at work, you document like you would, say, in your hospital environment with OBS and allergies, immunizations, etc. So, yeah, we've got a bit of a long answer to a really simple question, but I think the key thing is we're talking minor injuries, so we don't have to rush into something that potentially could, if you're with a big group, slow the group down. Finishing a day in daylight is always better than finishing it in dark if you've had to stop for an hour to potentially sort out quite a nasty wound.
So then what I'm getting there really is it is about the fundamentals. It's doing the basics well, and just like you said, making sure you factored in the time for appropriate wound cleaning and assessment before you dress a wound with a clean dressing. So I'm going to get you to speak to preventative care, but before I do, just because you made some fundamental points around paying attention to the basics, could I get you to tell the principles of minor cold injury treatment, maybe even indeed through the thumb story, if possible, and just attention to detail, because that story really typifies if the people on expedition don't pay attention to their minor injuries, they can really exponentially become uncontrolled.
So this was a story when I was working in Antarctica of a guided group that was ski touring up the Mount Vincent, which is the highest mountain on the continent. And there was a group as a guide, and he had an elderly client and a younger and 4 or 5 younger clients. And the elderly client was at the back of the group, and they were skinning up to one of the base camps. And the guy at the back had a problem with his bindings, and he tried to adjust them with a penknife that didn't have a locking mechanism on it. And as he was trying to adjust his bindings on his skis with this knife, the blade flicked back and cut his thumb. So quite a simple cut that a simple dressing applied and a bit of pressure would have stopped the bleed. And a simple elastoplast would have done the job. But this guy was worried that he was at the back of the group, he was slowing them down. And so he basically had a down mitt on, and he got a handkerchief out of his pocket or some tissues out of his pocket, and just put the tissue on the cut on his thumb and put it back into the down mitt. Now, in a normal environment, that would have potentially worked of just stopping the bleeding, but he hadn't controlled the bleeding fully, and the bleeding continued. Now he had a down mitt on, and the blood was absorbed by the down, and the down got wet. The down then froze, and he lost the insulation properties of the thumb on his mitt. So when he then got to base camp, he took his glove off, and this tissue was sort of stuck to his thumb. And when he managed to remove the tissue, he'd got a frostbitten thumb. Now, at that point, he'd spent sort of, I can't remember what the price was at the time, probably $40,000 on this trip to Antarctica to climb the highest mountain. And his guide said, "Look, you're not going any further. You've got a frostbitten thumb." And so he ended up coming back down the mountain the following day. But it was just a simple thing that a £1 dressing could have saved him nearly £35,000 trip. But this guy was just sort of worried about being slow. So there's the group dynamics, again, the human factors, the environmental damage of being in a tricky place at the time when it happened. But by not stopping the bleeding and dressing the wound, even with a simple dressing, would have prevented this chap from coming back the following year, having had a small amputation to his thumb to remove the frostbite, and spending another £35,000 really. So there was just that simple basic principle of stop the bleed. Yeah, they could have sutured the wound later on when they got back to base camp, but at the time, the simple principles of not stopping the bleed wasn't met. Got a wet thumb, led to frostbite, led to a small amputation, and came back the following year. So yeah, £70,000 worth of trips for the sake of £1.
Yeah, when you put it that way, it really does hammer home the adage of good basic wound care, because the second and third order effects are profound. But so could you speak to preventative care, Ben? And where my mind goes with preventative care is hot spots, preventing blisters, but also dehydration, and indeed other aspects of minor sunburn and wound infection. Could you speak to preventative care from your thoughts?
So in self-care, avoidance, I said the right equipment for the job. Like say down in Antarctica, the sun is 24/7. Sun cream, it goes on all the time, and a high factor sun cream. But the simple things that you don't realize, that you're skiing along with your mouth open because you're breathing in through your nose, out through your mouth. The sun reflects off the snow, so you end up getting sunburn in the roof of your mouth. You get sunburn up into your nostrils. So sticking sun cream on the end of your finger and sticking it up your nose is one thing, but wearing a buff will prevent the sun from burning the roof of your mouth from the reflection of the snow. You can't put sun cream inside your mouth. It's just one of those things. But unless you've been there and seen the damage that this caused, I think I saw a factor the other day that 80% or something of Swiss mountain guides have some form of facial cancer because they spend their summers on glaciers in the mountains, the high mountains, and they spend their winters on skis in there with the snow being reflected. Sun being reflected off the snow, so it's reflect off the snow in the winter and off the glaciers in the summer. So high factor sun cream. Say the correct equipment for the job. Going back to that chap with the knife, is making sure that your Leatherman multi-tool, your pen knife, has a locking mechanism on it. Correct footwear. I've been there, done that sort of. Bought a new pair of boots. Thought I'd broken them in, spent a lot of time in the mountains, and ended up with horrific blisters. It's buying the right kit for the job and spending time learning how to use it. A simple thing, that a leather work glove if you're working in a jungle environment, you're working with tools, equipment that just protect your fingers. Helmet, PPE in a way, helmet, goggles, sunglasses, the correct clothing to keep you warm, keep you dry. Stopping if you're tired, resting, make sure you're hydrated. Like the old phrase, a happy mountaineer likes to pee clear. Are we hydrated enough? Are we getting the right food? But also, like I say, going back to the right equipment for the right job. I was doing some teaching for a joint friend of ours and some of his colleagues, and they were I got shown some photographs of this horrific toe injury, and I said, "Well, what's caused that?" And he said, "It's some heavy boxes." And I said, "Well, what happened?" He said, "Well, during the day, the chaps were all wearing boots, and then there was some downtime, and then they suddenly got asked to do something very quickly, and they were moving these heavy boxes. One was wearing a pair of flip-flops, and he dropped the box, and it really much avulsed the toenail. It partially amputated the terminal phalanx of the toe, and this would have potentially been have stopped by having the right footwear on at the time. So when sometimes we switch off from the environment that we're in to then go into our sort of our downtime, and our brains sort of turn off a little bit, and that's when we potentially can get caught out. And there's a classic is people will spend a day with a pair of mountain boots on. They finish the day off and they take the boots off, take the socks off, and put a pair of flip flops on, and end up getting sunburnt feet because they didn't think about putting sun cream on the feet. It's with fuel, for example, a really easy way of getting frostbite in super cold environments is fuel spillage on hands. So if you're pouring fuel from your bottles into your stove, or trying to fix your stove, and you get fuel on your fingers in a minus 20 environment, that will speed up the chance of you getting frostbite. So I think there's a guy who passed away now. He ended up in a terrible accident in Greenland, a guy called Dixie Dancer, and he talks about wearing marigolds, having a pair of marigolds in your your stove bags, basically, so that you don't end up. So you put them on when you're working with fuel, just to protect your fingers, so they don't get fuel on them, which then gets cold if you're exposed to the wind, and then ventilates you the chance of you getting frostbite. Getting into jungle environments, being tired, and using a machete and slipping, and just end up chopping through stuff and end up with a sort of lower leg wound. And it's having that sort of 10 minutes on, breaking trail, then swap, breaking trail, and someone else breaks trail. So everyone is constantly in a rotation, that not one person is constantly slashing through and then getting tired, slips, and then ends up with a sort of a large machete wound.
So Ben, just looking at some of the principles of good minor burn care. So you've already spoken to just being mindful of sort of occult or hidden UV light. So just when you're not suspecting it, or indeed where not to put your guard down. But could you speak to, like you said, there's a lot on expedition around just minor burns when dealing with stoves or dealing with hot water or food. Could you speak to some of the principles there?
I think the difficult one, well, the easy answer with burns is basically 30 minutes of cooling water. So as soon as the burn happens, into cold water immediately. And cold water can become painful. So if you can change the temperature of the water a little bit into more tepid, and then we're going to put it under for a minimum of 30 minutes, and that runs up to 3 hours post burn. So if you refer a burns patient to the burns team, they will want it to have had 30 minutes of cooling. Even if the burn happened 2.5 hours ago, they still want that 30 minutes of cooling, which is great. And then you can put some cling film around it, oral analgesia, and then go to hospital if it needs hospital. But I think, if I'm saying environment in the sort of expedition world, where you're going to potentially, have you got a lot of cold water? Most people will have a litre water bottle with them. So you're going to pour that onto it. That's going to get it cold to start with, but it's not spending 30 minutes in cold water. So burns potentially become more difficult, because you want that ideally 30 minutes of running water, unless you can basically submerge the burn in a pan of cold water. So having some burns dressings are probably, people tend to carry cling film, but maybe not burns dressings. And sort of there are burns dressings on the market. The significant burns, you've got to worry about the patient then getting cold, and hypothermic. But generally, it's having that water source to cool down, and maybe you just have to pour a litre of water into a pan, or empty a hot pan that's got hot water in it, away, fill it full of cold water, and just submerge the fingers, the toes, whatever's been burnt. But it's the common things are common, and things that tend to have burns that tend to be finger ends, and being able to dress a wound on a finger with, they say, Atramin or Ergotul. Again, it depends what you've got in your med kit. But some of the burns dressings are very good at quickly cooling and leaving on for a longer period of time. There was a recent, only in the last month, I think, up in Scotland, there was a bothy, sort of small mountain hut that there was several people inside of it, and one of them had a problem with the stove, and they tried to change the gas, or they didn't put the gas stove together properly, and there was a slight leak they didn't realise, and when they lit the gas, the whole stove just exploded, and created only minor burns to those who are trying to lift it and throw it out of the hut. But again, potential for the gas canisters to explode is quite significant, and that could potentially cause more sort of catastrophic injuries that have gone from a burn to a sort of a hemorrhage control situation. But in general, 30 minutes of cool water, wrap in cling film. I tend to carry a small, you can get them on eBay actually, they're about sort of 4 inches long, a roll of cling film and there's probably about 100 meters on it, but you can use them for burns, but also if you've wanted to splint someone's legs together and make them one unit, because it's easier to shift one unit rather than having flailing legs, it becomes a secondary bandage, really. You can splint it around the thighs, splint around the lower legs. You can make a sling out of it. So it's got many uses, and from an expedition point of view, you want to be carrying stuff that has the potential. I guess it burns to the fingers, for example, using a sandwich bag, putting a hand in it with a bit of water in a sandwich bag and bandaging it around their arm. And that's what I say on a burns unit would have burns bags. You might not have a sterile burns bag with you on your med kit. Why would you? Why not just use an IKEA sandwich bag or a Tesco sandwich bag? It's there. Put some water in it. It'll do the same job. So it's just improvising at times, adapting and overcoming the problem.
Ben, could you speak to incised wounds and some of the principles you look at when you assess incised wounds, and indeed when you treat, clean and close incised wounds?
So incised wound is a wound that's been caused by a blade, and again, the first principle is always like stop the bleed. Stop the bleed, and that may involve potential of the bigger, the fancier dressings out there, the Celox gauze, the Celox roll, the Celox powder. But again, if we're talking minor stuff, then there's just apply digital pressure, stop the bleed, and then once you've stopped the bleed, work out an assessment of the wound. How deep is it? Can we see the base of the wound? Now, it depends on your skill set, what you've done as a junior doctor or a paramedic or an advanced nurse practitioner, to what level of skills you've got. Do you feel confident in actually what can we see in this wound? Is there any deep structures involved? Is there any tendon damage? If there is, we just need to pack the wound, put a dressing around it, and move that person out to a better place to get the correct treatment. Or if you're quite confident in the fact that there's no deep structure damage, have you got the skill set to put some deep sutures in there, or does it just need a couple of sutures on top or some steri strips? But in general, that comes with a good assessment, size, depth, structures involved. Have we got a good light to make sure we can actually see the base of the wound? And if we haven't got we haven't got the skill set, then packing the wound, keeping that wound moist, potentially using a SAM splint to bandage it. If it's a wound to the hand, makes it rings have been removed. There's that we talk about what's called the Edinburgh position, where the hand is held in sort of extension at the wrist, where so the fingers are slightly curved, and using a SAM splint to keeps the tendons in maximum length, and bandaging it on, elevating it up, and moving out to somewhere where we can get a better management. I think, say, hand injuries are the biggest payout in sort of legal fees when it comes to hospitals. And I think for me, what keeps me safe in my practice at work should keep me safe in the expedition world. I'm not going to start doing tendon damage surgery. I don't do it at work, so why would I do it out in the field? And if in doubt, ship them out.
Absolutely. Could you speak to fungal infections, because that seems to be quite commonplace on expedition, such as athlete's foot and others? Could you speak to some of the salient treatment principles?
I think from what we see down in Antarctica, foot care is clean footwear, dry footwear, using foot powder, but also taking your boots apart at night and then airing them in your tent. So you've got to the following day, you're putting on dry socks, dry footwear, but every evening you are putting foot powder, making sure your feet get some fresh air in the tent, putting some foot powder on them, getting amongst the web spaces, and but also thinking. Lots of put med kits together are thinking of it's not all about the CABC. A lot of the problems are that if we don't treat the simple things like this, they get bigger, they get worse and worse and worse. So I say carrying foot powder, carrying antifungal cream. And it's that part of that, I don't know, it's a military thing of if you look after your feet, basically, because your feet carry you, whether you're running, you're skiing, you're cycling, the feet are an important tool. Make sure your toenails are cut short. But in general, it's that methodical, at the end of the day, taking your socks off, cleaning your feet, putting some powder on. Make sure if you go to bed with socks on, you go to bed with dry socks. You put your wet socks in the roof of your tent so they dry out, or outside on it under your basher or something like that, just so the following day you're putting on dry kit. Now, I mean, leather boots take a lot of time to dry off, but simply by removing the footbeds, holding them upside down and allowing warm air to get inside of them. Again, if you're in the jungle, banging them out in the morning to make sure there's nothing has decided to take habitation inside your boots. It's very common, these kind of things, in adventure races where you don't have time. I remember you sending me a picture of a chap's foot from the jungle, and it looked like someone had basically got 3 crumpets and stuck them on the sole of his foot. And then it's as adventure races, you're going from A to B fast, and you haven't got time to stop and treat your feet. If you're in the winning teams, you are going to keep going. Whereas others, if you've got a period of like a base camp or a stopping point, some people will have a spare pair of trainers or some spare footwear, a dry set of socks, some foot stuff, and then they start the next section with dry kit. But if you're on a polar travel, you're not going to have a spare set of boots. It's having that routine that at the end of the day, I've got to be bothered to do this. And if you're not bothered, then that's when you're going to get caught out, and a fungal infection will lead to potentially a cellulitic foot problem that's going to potentially lead on to breaking into antibiotics that could potentially then break into potential sepsis, that when you are halfway to the South Pole, that becomes a major rescue. In the middle of a jungle, it becomes a major rescue. In the mountains, it's all things to consider, is weather, and with all these things that we're discussing, weather, evacuation, where are we? Where's help? And how can we get help? It's all right calling a helicopter in the jungle, but if the helicopter hasn't got no winch facility, then the helicopter's a helicopter. You're just going to wave at it.
Absolutely, to that point, Ben. And just like you said, it's around doing the basics well, but also the preventative care to stop the sequelae of the injury becoming bigger. But just to your point around infection, actually, so just looking at localized infection with erythema and just reddening, could you maybe speak to what you're looking to rule out, and what are some of the general principles of localized swelling that you would be mindful of when assessing a wound?
So with infection, we're looking for your worst case scenario is always sort of sepsis, but in general, heat, swelling, pain, redness, temperature, ascending lymphangitis. So it's the simple, like someone got like a red pen and drawn it from the wound up their arm, up the leg. And sometimes, again, in bad light, you might not spot it. So having a good torch, good examination, is there any pus coming from the wound? Is there a foreign body in there? Have you put the foreign body in, i.e. having closed it with a suture? Do we need to release that suture? Is there a range of movement in the joint? Has the joint suddenly stopped moving as much as it has done? Antibiotics, do we start them early? Do we need oral? Do we need IV? Again, these are things that we need to, when putting your med kit together, you need to think about where we are, what we've got. If you've got oral antibiotics, then we've got great. We've got tablets. If we've got IV antibiotics, then we need to carry cannulas. We need to carry, and say some of these things that involve weight. And when you are racing to the South Pole to beat records, adventure races, you're not going to be carrying a tourniquet, a cannula, a wound clean, skin prep, cannula dressing, 10 ml syringes, flush, to mix the antibiotics. Again, things to consider. I carry a Sharpie pen. So do you suspect an infection around a wound? Do we treat antibiotics there and then, or do we get a Sharpie pen out and just mark it off? And then keep an eye on it, educate the person to, if it gets past the certain point, then we will go down the antibiotic line. I remember a couple of years ago, we were looking after a chap who was rode from New York to Falmouth, and he got an infection in his foot within about 5 days, a week in. And he was fresh and he was strong, so we chose to go down there, just mark it with a Sharpie. Good foot care. Again, it was back to the foot thing. Foot management, dry feet, fungal powder. Went to bed every night, and the infection never got past the Sharpie marker. But when he got back, sort of, when he rode, I can't even tell you, 6 weeks, he had a similar problem, and we then chose to go down the antibiotic line then, because he was worn out. He'd been rowing for the last 6 weeks, so he hadn't got the reserves to fight the infection that he did at the start. And again, you've got to look at the antibiotics. How many have you got? Have you got one course with you? Have you got 2 courses with you? It's things to juggle around in the thought process of like where you are. Again, if this infection goes wrong, where are we? Where's help? do we need to get that person to somewhere so help can get to them, whether that be by road, by river, by plane? And all these things are weather dependent, and rescue, evacuation, it all needs to be played into our mind. Again, simple things done well work, but if we don't do the simple things well, the potential of say something that could easily be seen, sorted and dealt with go wrong, it could end up leading to a multi-thousand-pound rescue. So again, it's, do we treat early antibiotics? Do we not? It's got to take these things into consider. I don't think there's any right or wrong answer, but there's things that when you're hospital based and then no longer hospital based, these are things to take into consideration. And again, with dressings, there's a lot of simple dressings I like the Opsite, for example. You've got a cling film, a sort of cling film edge with a square dressing in the middle. Now you can say to someone, we've cleaned it, we've sorted it out, we've closed the wound, and we put an Opsite on it. But if anything appears outside of this dressing, you need to come back. Now, they're great dressing it in our everyday climate. However, if you're in the jungle where it's hot and sweaty, and these dressings don't stick to the skin at all, so you end up going down the old-fashioned but the non-adherent dressing with a toe to knee bandage or wrist to joint, because you should be bandaging from joint to joint. Now, if you do that, you need to probably on daily basis roll down that bandage to make sure that you've got no ascending lymphangitis, because potential by the time you find it, it could be halfway up a limb. But by that time, you'd have thought that pain would have kicked in. The patient should know, but part of you as a practitioner should be educating your patient at the same time.
Ben, could I get you to speak to abrasions? Abrasions can be super painful, especially large ones. What's your approach to large, painful abrasions?
So in Yorkshire, they call it taking the bark off. I've taken bark off, so the bark is your skin, and it's really common with sort of these days with cyclists, road rash or gravel rash, and it's super painful. It takes a lot of sort of superficial layering of the skin off, but when you tend to come off, say for example a mountain bike, you end up, as you slide down the dirty surface, you're forcing dirt into a wound, and potentially not just dirt, but stones as well. So you end up with a large wound that's potentially got dirt inside of it, foreign bodies. So cleaning it is something that takes time, and that might involve putting some local anaesthetic in all over the wound, or some people talk about using lignocaine gel and smearing it over a wound to start with, and before we start using like maybe a surgical brush to remove the dirt. And again, like we said before, the solution to pollution is dilution, so lots and lots of warm soapy water. Or if you got, or if it's on a leg wound, it's in the bath, and just to clean it. And if you haven't got a surgical brush because you're on a cycle from a common cycle expedition type thing, is from one side of Costa Rica to the other, a clean toothbrush just to put a little bit of pressure, just to make sure there's plenty of time is spent to remove as much as the dirt as possible, and especially the larger chunks of stone, because if not, you end up, the skin grows over and you end up with tattooing, which is basically where you've got black marks in amongst the skin. It's potentially planning. So if you're going as a medic on a cycle trip, common things are common, so expect gravel rash as part of your potential injury that you're going to be treating. where you may not be treating gravel rash. You're not going to try and gravel rash on a polar trip, for example. So having some flamazine with you. So flamazine is like sort of a white paste that you can leave on a wound and leave it on for 24, 36 hours and then wash it off. And that flamazine will help lift out any dirt. And then putting on a good, the right dressing would be something maybe Silflex or Ergotool, something that can stay on for a good sort of 4 or 5 days, really. We talk about dressing changes on a daily basis, which is great if you've got a hospital. But if you're limited supplies, you can't do things on a daily basis. And when you change something on a daily basis, you often remove the fresh granulated skin anyway. So with things like Ergotool and Silflex, they're two fantastic dressings that would be my sort of Swiss Army knife of dressings. If I'm going to take one dressing on a trip, I'm going to probably take one of those. And you can leave it on for several days. But also, they're very clever dressings that you can actually wash a wound through them. So you can leave the dressing on, and you can then just pour water over it just to keep it clean. But it allows granulation to occur underneath, whereas the old-fashioned stuff that used to use was Gelinet. If it's left on too long, skin can actually impregnate through the Gelinet, and you might find that with patients that don't really attend clinics, for example. They come in, they've got a problem, you dress it, and you say, I want to see you next week at a certain time. This patient may not turn up because they're just not focused. They've got other things going on in their life, and they may represent 6 weeks later, and by that time the skin's actually grown through, and the Gelinet is impregnated into their wound, which then becomes a further problem. But with the things going back to cycling events, is being able to dress a knee or an elbow so you can still continue your trip. If you've got a big grazed gravel rash on both knees, being able to dress it properly so that person can still cycle. Being able to dress an elbow so that the wound can still, the elbow joint can still bend. Because if you're not, that potential, you've got to either carry that person out. That person has gone from cycling, which is quite fast, to then walking, which changes the group's dynamics, which changes the human factors of your expedition. And the simple things like I remember seeing a junior practitioner dress an elbow, had gravel rash down both elbows, and this person they'd been cleaned and the elbows had been dressed, but they couldn't bend their arms. So when that person left the department, they were sort of a bit robotic, and they were unable to flex their arms at the joint because of the bandaging was so tight, which then potentially can lead on to, if you can't bend your joints, leads on to that person their activities of daily living can't be achieved. So brushing the teeth, eating, dressing, wiping the bum, it's all problematic. So having that ability to think about where the wound is, how we're going to dress it, and that person able to continue with the event or their activities of daily living, because potentially that problem will come back to you in the long run. And also being able to use a joint. You don't want the joint stiffening up, causes, again, the whole sort of circle of wound care. You need movement, you need air, you need joint space, etc., etc. All becomes a big problem from not treating the little problem, which needs, again, time.
Ben, could I get you to speak to blisters? The common adage is that blisters can be trip ending if they're not dealt with early. But could I get you to speak to what you do for blisters in the field?
So blisters is a triad of friction, moisture, and heat, basically. And again, it's having the right footwear for the job, spending time in those footwear before going away on a trip. And if you're an expedition medic, but it's also part of education, doing a pre-chat with your expedition about treating the hot spots. So as soon as you get a hot spot, which is where you think you're getting the friction starting, you're getting a bit of a warm spot on your foot, and it's about basically stopping and treating it pretty much there and then. And that hot spot might just need potentially your socks just adjusting a bit. There might be a ruck in the sock. You might just need your boots loosening off or tightening up, and it just potentially having some tape just put over it, or a compede, because it's at the time there's no fluid build up there. We've got a bit of friction, so putting a compede over that. And applying tape. But before we're doing that, make sure the feet are dry, because tape's not going to stick to a wet foot. The compede's not going to stick to a wet foot. So clean the foot, make sure it's dry, apply a compede dressing over it, and then apply tape. With the tape, probably use something like KT tape, because it's got lots of other uses. Is using a pair of scissors to cut the tape, not to tear it. Because when you tear tape, you often get these fibers that appear, and they get stuck in the sock when you put the sock back on, and then that lifts the dressing off. So over tape, but cut the tape. Try and cut the tape into cut the sharp angles out of the tape. So cut the corners. Apply the tape over the compede, and make sure it's well secure. And then roll the sock on. Don't put the sock on like you would with welly. Roll the sock up and put it on gently, and there's less chance of it disturbing the dressing. But if you have got a blister, then there's fluid already there. A fluid-based dressing is too late. So you're putting fluid on fluid, and if you've had a pair of ski boots fitted or a pair of mountain boots fitted, you're potentially not going to get them on if you've got too much of a dressing. So in that way, I tend to use a sterile needle and just pop the blister, drain it, and maybe or needle and thread, and just leave a bit of thread through the blister. So you pop the needle on one side, pull it out the other side, cut the thread, and that acts as a wick, so it drains the fluid off. And then maybe put some moleskin over the top, or some just KT tape directly onto it, and that allows the blister, it's Mother Nature's sort of cover skin, to just fall back onto the blistered area, but then we're protecting it with some nice moleskin or some KT tape. Having a blister management kit near the service, because common things are common, and you're pretty much guaranteed to get blisters within the first sort of couple of days of a trip. And having a little supply ready, so in there you've got KT tape, you've got compede, you've got a pair of scissors, you've got a needle and thread, you've got some moleskin, so you've got all your stuff, so it's all there, labelled up blister kits, so you haven't got to rummage around for it. There's a couple of obviously the British Mountaineering Council, their website has an interesting take on blister management, or one of the World Extreme Medicine doctors, she's got a fantastic bit on her blog site, Dr. Hannah Locke. I've never met Hannah, I know of her, but on her blog, she has a really, really, probably the best actual blister management write-up that I've seen, and it has made me change my practice. But yeah, it's again, it's education, and spending time treating it properly. And once you've put this stuff on, is leaving it on. Whereas often when you do events, people, if they're on a day-to-day trip, they will sort of have a shower and they'll take it all off, and you're back to square one again. And I think once you put your blister management stuff on, it stays on, and you educate them to leave it on, unless you start getting pain redness, swelling, potential signs of infection, and we're removing it all and starting from scratch, and then potentially treating the infection.
But just before we come into land, actually, could I get you to speak to sprains and strains, because they are commonplace on expedition and they do occur frequently? What's your approach, either pre-hospitally on a SAR, search and rescue incident, or indeed on expedition?
So sprains is twists of ligaments that have been stretched too far, and a strain is injury of the muscle or the tendon. You go down when on assessing the limb, is a look, feel, move. Is any swelling, any heat, any deformity, any bruising, and yeah, the once I've done that is the look, feel, move. Having some knowledge of the Ottawa ankle rules, the Ottawa knee rules, the Nexus rules is good. However, I have seen in my years of practicing, I have seen people who have been Ottawa negative or been in their notes as Ottawa negative, been Ottawa positive. That the X-ray has proved that that person has got a fracture. Now, you're not going to have an X-ray machine with you on an expedition, but that sort of having that background knowledge of the Ottawa ankle rules is useful. It's analgesia, splinting, good old-fashioned crepe bandage, using of walking poles, reducing weight in the person if they're carrying a rucksack, reducing their weight. Can we put in some rest days? We're going on the rest days. We're going to then elevate it. Again, it depends where we are, what we're going to do. We want that person ideally to carry themselves out, because suddenly, if one person at, for example, 12 stone, then needs carrying out, a rescue team, that means a one stretcher and minimal of 6 people on a stretcher, but ideally 8 on a stretcher. Now, if you're in the middle of a jungle, that's a hard work. If you're on a narrow mountain pass, that's hard work. So, yeah, the mechanism of injury is key. That'll often tell you your diagnosis. Good examination, plenty of analgesia on board, having an understanding of potential what over time and examining wrists and elbows and shoulders and knees and ankles, you get to feel for what potentially could be the problem here, and what have you got with you that you can deal with this? Can we deal with this? And it may be the fact that that person is going to have to continue walking out. If not, if in doubt, ship them out. And that, again, depends where you are, what resources you've got available, to what kind of sort of rescue that needs to undertake. But I think, again, sometimes with these things, we've often seen that injury that's limped into the department, had no analgesia. You give them some analgesia and they walk out 2 or 3 hours later with a pair of crutches. Now, you don't have a pair of crutches, but you might have a pair of ski poles. You might have some walking poles with you. We had a client down in Antarctica. We ended up making some crutches out of some bamboo that was from the frame, the flags that were using to mark out a runway for the American ski 130s. There was some excess bamboo that were on these flags, and so we made this client a pair of crutches so he could get around the camp with his broken leg.
And as we're coming into land on the conversation, could I just get you to speak to some take-home messages for listeners that you'd like to mention just around some of the fundamentals of good wound care?
I think for me, it's spending time with, if you're going out as a medic and you're not familiar with sort of the kind of stuff that emergency nurse practitioners use, a lot of this stuff is minor injuries. Minor injuries a lot of these days is taken over by emergency nurse practitioners or advanced nurse practitioners in an ED. So it becomes a de-skilling of potential junior doctors. So spending time in an A&E or minor injuries unit with emergency nurse practitioners and upskilling yourself, asking their questions. What does this do? What can I use this for? Is this, do I need to take this, or what would be your sort of Swiss Army knife of dressings? Some good books out there. There's always the Expedition Wilderness Medicine Handbook, written by the World Extreme Medicine faculty, or the Oxford Handbook. Going back to the feet one, there's a fantastic book by Wilderness Press called Fixing Your Feet. There's what other great books? So there's a fantastic one written by the Swiss mountaineering board, like the Swiss equivalent of the British Mountain Rescue Council. But in general, most people these days will have a smartphone with them. So if you've got a wound, doing a photo diary of the wound on a daily basis, so you've got something to compare to. Don't be afraid to ask a friend. So if you've got photographs and you've got some sort of either Wi-Fi coverage or some phone coverage, or you've got a satellite link, send some images. If you're not sure, send some images back to a friend who you've said, I'm going away on a trip, I'm going to be away for 6 weeks, do you mind being on call for me? Or allocate 3 or 4 friends. And I've had that several times. I got a message last year from a friend who was out in Africa, I think it was. I know they got someone got drunk and ended up with some significant burns to an arm. What would you do in this situation? But if they say, so don't be afraid to ask a friend. Photo diaries. If in doubt, ship out. Just spending time within a minor injuries unit is great. Common things are common, and sometimes some of the simple things like elastoplasts are often missed out of med kits. Some form of evacuation, some like a stretcher or a small poncho style stretcher is missed out of a med kit. We are very good at. I've been on many a WEM course with yourself, and people are asking for elastoplasts, and the room's full of HEMS medics or military medics of all walks of life, and they've all got chest drains in the CABC kit, but often the simple things are what we use on a regular basis that get missed, like a simple elastoplast. There's quite there's a lot out there, but emergency department procedures is another good book. But in general, doing the basics well is key, and spending time thinking about what have we got here. Let's spend some time dressing it properly rather than rushing, or do we need to put a simple dress on it, move on till we've got some better light, better situation, dressing it properly, and hopefully, fingers crossed, that person will continue their expedition or go home from wherever they are and have no problems. But also reiterating to your patient, if you get any problems like heat, pain, swelling, red line coming up your arm, come back earlier, rather than, especially earlier if you're in the middle of the jungle or wherever. But if you're working from a clinic anywhere in the world, is to say to signpost them to come back within 48 hours, a week, 2 weeks, and have that fallback mechanism.
Ben, that's fantastic, and I think that's really holistic. From everything you mentioned there around doing the basics well, to phoning a friend, to indeed shipping out early. But it certainly is the prerequisite of all good wound care is doing the basics well and the fundamental tenets of self-care. So listen, thank you for your time today. Really do appreciate it. And we'll put some useful links in the show notes to the books that you mentioned. But thank you, Ben.
All right, we've got just two more seconds. So if you, my summary of what here is treat the environment. So bothies before bandages, stepwise approach, basic interventions normally work well. Don't underestimate blood loss, pharmacological steps and practical steps, and putting med kits together. Jack Kindler, lovely lad from London who used to run the Diploma Mountain Medicine. He had, when it came to med kits, the 4 Ls, which was legal, low cost, light, and lots of uses. But with every patient, as I've always said, even on a daily basis, so good food, hydration, and fresh air. And don't sometimes allow fresh air to get to wounds. We often want to put a dressing on it when actually sunshine, fresh air allows the wound to sort of granulate rather than keeping on applying creams, dressings, and creams and dressings. Bit of Yorkshire fresh air, mate. Fish and chips on a Friday and oodles of Yorkshire tea.
That sounds good to me, Ben. It sounds good to me. And it certainly does the population of Yorkshire good as well. But listen, thanks for your time today.
Cheers, mate.
Thanks for listening to the episode. Please feel free to rate, review, and subscribe on whichever platform you're listening to. Please also head over to the World Extreme Medicine website where you can find more engaging content on extreme medicine webinars and indeed the collection of courses from our global network, including humanitarian, disaster relief, expedition, space, military, tactical, and performance medicine. Thanks again.